Hello everyone, I'm Dr. Monica. Today in this video we will learn to take complete case history of a periodontal patient. So let's begin. Starting with the definition, a case history is defined as a planned professional conversation that enables the patient to communicate his or her symptoms, feelings, and fears to the clinician so as to obtain an insight into the nature of patient's illness and his or her attitude towards them. So basically, case history is a detailed information about the illness of the patient, which is told to the clinician, upon which the clinician can make diagnosis and further plan the treatment. So coming to the objectives of taking case history, it is taken so that a positive professional relationship is established between the patient and the dentist. Second, it provides the clinician information about the patient's past dental, medical, and personal history. Also, it provides information which may be necessary for making a diagnosis. Lastly, the information provided aids the clinician in making decisions so that a treatment plan can be made. Coming to the components of case history. The first component of case history is the personal information of the patient, followed by the chief complaint, that is the illness with which the patient presents to the hospital, followed by history of present illness, past medical history, past dental history. Patient is asked about the family history and personal history. Then the clinician examines the patient clinically. Firstly, extraoral examination is done, followed by intraoral examination. Then the clinician makes provisional diagnosis, records are taken, investigations are done wherever necessary. Final diagnosis is made by the clinician and prognosis is predicted, and after obtaining all this information, treatment plan is made. So let's begin with the personal information. The first personal information we obtain from the patient is the name. It is important so that we can communicate with the patient. It also establishes a rapport with the patient. It is important for record maintenance, and also it provides psychological benefits to the patient whenever we call the patient with his or her name. Coming to the next component, that is age or gender. This is important since few diseases or conditions they are more common in certain ages. For example, tongue tie, cleft lip, they are more commonly present in the children, whereas we can see that attrition, diabetes, they are more commonly present in the adults. Coming to the significance of gender, certain diseases they are gender specific. For example, attrition, leukoplakia, cancer like squamous cell carcinoma, they are commonly found in the males, whereas iron deficiency anemia, Sjogren's syndrome, and osteoporosis, they are more common in the females. Also in females, we have to take special consideration during their pregnancy and lactation to prevent any kind of drug interaction. Next is the OPD number. It is useful for maintaining a record. It is also used for making bills, and it is helpful in some medical legal aspects. Next is the address. We ask the patient about the address to get a rough idea about the socioeconomic status, about the nourishment, hygiene, and the paying capacity of the patient to any treatment. It is also useful for future correspondence. Also, if the patient lives in an area with high fluoride content, it tells about the prevalence of disease like fluorosis. Next is the occupation. It tells about the socioeconomic status of the patient. Also, certain diseases they are more common in some occupations. For example, dentists and surgeons they are at high risk to acquire hepatitis B. Next is the marital status. This is asked to see any history of consanguineous marriages. Since few dental disorders they are genetically related due to inheritance of recessive traits in such kind of marriages. Coming to the second component of case history, that is the chief complaint. It is the illness or the reason for the patient's visit to the hospital. It is stated in patient's simple words. Whenever it is noted down, we follow the chronological order and the severity of the symptoms. Chief complaint, it aids in the diagnosis and treatment, therefore, it should be given utmost priority. The commonly encountered chief complaints are pain, gum bleeding, foul breath, ulcers, and etc. So let's understand the chronological order of a chief complaint with an example. Think that if a patient reports to you that he or she has tooth pain which started 2 months ago and a gum swelling which started 3 months ago. So in the chief complaint, we will write down that the patient complains of tooth pain in right lower back region for past 2 months. Also, the patient had gum swelling in the same region since 3 months, which subsides on its own but reoccurs occasionally. Next component of case history is history of present illness. It is basically an elaboration of the chief complaint. Also, relevant associated symptoms are asked to the patient. The symptoms can be elaborated in terms of mode and cause of onset, the duration of the symptom, location, whether it is localized, diffuse, referred, radiating in case of pain, progression, that is, whether it is continuous or intermittent. We can ask the patient about the aggravating factors and relieving factors. Also, we can ask about the medications undertaken to treat that symptom. Coming to the medical history, we have to ask the patient about the past and present illness. And if there is any illness present, it should be recorded in chronological order. It should include if the patient is under the care of a physician, nature and duration of the problem is to be noted. We have to ask the patient about any kind of hospitalization, any operation, and if any operation has been done, we have to ask the patient if there was any complication during the operation. We have to ask about ongoing medications, the medical problems like presence of diabetes, hypertension, thyroid, any possibility of occupational disease, abnormal bleeding tendencies, and patient's allergy history has to be noted down. In cases of females, we have to ask about the onset of puberty, menopause, any kind of menstrual disorders, if miscarriages are there in the pregnant female, or any history of hysterectomy is present. Coming to past dental history, this tells us whether it is the first dental visit of the patient or not. Or if the patient had previous dental treatment, we ask him or her about tooth filling, scaling, root canal treatment, surgical procedures, tooth extractions. We also ask the patient about reasons for tooth loss, any untoward complications during dental treatment, fluoride history, including supplements and the use of well water. This also tells us about the attitude of the patient towards previous dental treatment. We ask the patient if he or she had experience with orthodontic appliance and dental prosthesis, or if radiation was taken for any facial lesions. Next important component of case history is the family history of the patient. We ask the patient if there is any genetic diseases in the family, bleeding disorders, mental disorders, hypertension, cardiovascular disease, renal disease, diabetes, cancer, asthma, or any allergy to any drugs. Talking about the personal history, we ask the patient the diet, that is, if the patient consumes vegetarian or non-vegetarian food. In non-vegetarians, we can see more wear and tear of the teeth due to the fibrous component of the food. Next, we come to the oral hygiene history of the patient. In this, we ask the method of brushing, the type of toothpaste and the toothbrush, and how frequently the toothbrush is changed. Also, we ask the patient if the patient uses any interdental aid. Next, we ask the patient about deleterious habits, whether the patient consumes alcohol or smoking habits, or if he has tobacco chewing habits. Next is oral habits. In this, we take into consideration about bruxism, tongue thrusting, mouth breathing, and clenching habits. Next we have is the clinical examination. It has two components, extraoral and intraoral. First we will talk about the extraoral examination. In this, firstly, we check for the presence of swelling or asymmetry in the face. Secondly, we examine the temporomandibular joint. First, by checking the presence of any deviation in the path of mandible by asking the patient to open and close the mouth. Then we look for the presence of any abnormal sound, that is clicking and crepitus. Then tenderness is checked over the joint or masticatory muscles. Thirdly, lymph nodes are palpated to check for any tenderness or swelling. If on palpation of lymph nodes, that is preauricular, postauricular, occipital, submental, submandibular, cervical, there is presence of swelling or tenderness, then we can suspect the presence of superficial facial space infection. Coming to the intraoral examination, the first thing we check is the malodor, that is whether the patient has bad breath or not. For this, the gold standard is the organoleptic test, in which a trained examination smells the patient's breath and, depending on the intensity of the odor, gives grading. So, according to the Rosenberg scale 1992, there are 6 gradings. Grade 0 represents the absence of foul breath. Grade 1 is questionable. Grade 2 is slight malodor. Grade 3 is moderate. Grade 4 is strong. And grade 5 is severe malodor. Next we check is the occlusion. In this, the molar relationship of the patient is checked by Angle's classification. If the mesobuccal cusp of the maxillary first molar occludes in the buccal groove of the mandibular first permanent molar, it is class 1. In class 2, distobuccal cusp of upper first molar occludes in the buccal groove of lower first permanent molar. In class 3, the mesobuccal cusp of maxillary first permanent molar occludes in the interdental space between mandibular first and second molar. Next, we examine the other oral structures. First, lips are checked for any change in color, texture, competency, whether there is presence or absence of any angular or vertical fissures. We check for presence of lip pits, scars, cold sores, ulcers on the lips, scab formation, and keratotic plaque presence. Now, looking at the tongue, we look for the size of the tongue. We look for the distribution of the papilla, check for any abnormality, presence of any ulcer, tongue tie, and enlarged tongue due to conditions like lymphangioma, hemangioma, and neurofibroma. For buccal mucosa, we check for the presence of any ulcer, whether there is presence of any white patch or neoplasia, which may be indicative of any precancerous lesion. We check for any kind of abnormal pigmentation on the buccal mucosa. For the floor of the mouth, we check for presence of any swelling, ulcers or red and white patches, presence of ranula, which is unilateral bluish translucent cyst over the Wharton's duct, presence of ankyloglossia, that is the fusion of the tongue and the floor of the mouth, and we also check for presence of any carcinomas. For the palate, we check for any discoloration, presence of any swelling and tenderness, fistula, if there is papillary hyperplasia, if there is a presence of tori or ulcers, recent burns which reflect the change in the color of the palate, leukoplakia, or if there is presence of any asymmetry of structure or function. In the vestibule, we check the depth of the vestibule. We look for any overgrowth or whether there is swelling or tenderness in the vestibular area. The presence of fistula and ulcers are also checked, and recent burns, white or red patches, scars and scabs are also looked in the vestibular area. For the saliva, we ask the patient about the amount by asking questions like whether the mucosa is moist, dry, or it is covered with scanty, frothy saliva. We look for color and the consistency of saliva. Now we check for the presence of high frenal or muscle attachment. According to Mercopi et al., frenum attachment can be mucosal, gingival, papillary, and papilla penetrating. So the role of high frenal attachment is in the formation of midline diastema and recession in the upper central incisor region. Now talking about the hard tissue examination, the first thing we check here is the teeth. In this, firstly, we will write the notation of the teeth present, the number of missing teeth, We'll look for the size of the teeth and check the color of the teeth. Next we look for is the presence of any wasting diseases. Firstly, we check for presence of abrasion, which is the loss of tooth substance induced by mechanical way other than that of mastication. Secondly, we check for presence of attrition. In this, occlusion wear is seen resulting from functional contact with opposing teeth. Thirdly, erosion, which is sharply defined wedge-shaped depression in the cervical area of facial tooth surface. Lastly, we check for is abfraction resulting from the occlusion loading surfaces, tooth flexure, mechanical microfracture, and tooth substance loss in the cervical area. Next, we check is the presence of any fractured teeth. We look for dental stains. For this, Lobin stain index is used. Then we check for the presence of any caries in the mouth or if there is any restorations done by the patient. Then we look for is the presence of calculus. Next we check for is the proximal contact relationship. In this, open contact allows for foot impaction. Also, abnormal contact relationship results in midline shift between the incisors. There can be presence of labial flaring of maxillary canine. Also, buccal or lingual displacement of posterior teeth can take place and uneven relationship of the marginal ridges are present. Next is the tooth hypersensitivity. It can be located by gentle exploration with a probe or cold air. Next is the soft tissue examination. In this, first we look for is the gingiva. The color of the gingiva, it is usually coral pink, but it can vary between reddish pink depending on the state of gingiva. Physiologic pigmentation may also be present due to the presence of melanin. Contour of the gingiva, it is scalloped or knife edged. Next is the surface texture. In healthy gingiva, we can see the presence of orange peel appearance, which is viewed by drying the gingiva under natural light. Coming to the size, there can be an overall increase or decrease in the size depending on the vascularity and the cellular elements present in the gingiva. Talking about the position of gingiva, it can be either apical or coronal to the cemento-enamel junction. So, according to Miller, recession can be categorized into four classes. Class 1, in this, marginal tissue recession is present, which is not extending to the mucogingival junction and underlying alveolar bone, and there is 100% root coverage, which can be anticipated. In the class 2, there is marginal tissue recession, which extends to or beyond the mucogingival junction, and 100% root coverage can be anticipated. In the class 3, marginal tissue recession is seen which extends to or beyond the mucogingival junction along with the partial root coverage. In class 4, there is marginal tissue recession which extends to or beyond the mucogingival junction and root coverage cannot be anticipated after treatment. Next is the consistency of the gingiva. In healthy gingiva, we can see the consistency is firm and resilient, and in unhealthy or diseased gingiva, the consistency is usually fibrotic and edematous. Next is tenderness on palpation. Then we look for the presence of any suppuration. Next we look for is the ease of bleeding. This is an important parameter since bleeding on probing is an earlier sign of inflammation compared to gingival color changes. To test for this, the probe is carefully introduced to the bottom of the pocket and it is gently moved laterally along the pocket wall. The clinician should recheck for the bleeding 30 to 60 seconds after probing. As a single test, it is not a good predictor for progressive attachment loss, but its absence is an excellent predictor for periodontal stability, meaning that if bleeding on probing is absent, we can surely say that the gingiva is healthy. Coming to periodontal examination, we first look for is the presence of tooth mobility. Mobility is graded clinically by holding the tooth firmly between the handles of two metallic instruments or with one metallic instrument and one finger. According to Miller, tooth mobility is graded into four categories. Grade 0 means that there is no detectable movement when force is applied other than what is considered normal physiologic movement. Grade 1 is mobility greater than the normal. Grade 2 is mobility up to 1 mm in the buccolingual direction, and grade 3 represents mobility greater than 1 mm in a buccolingual direction combined with the ability to depress the tooth in the alveolar socket. Next we look for is the presence of furcation in the molar region. According to Glickman, furcation is categorized into four grades. In grade 1, there is pocket formation into the fluid, but intact interradicular bone is seen. In grade 2, there is loss of interradicular bone and pocket formation, but not extending through to the opposite side. In grade 3, through and through lesion is seen. In grade 4, through and through lesion along with gingival recession, which leads to a clearly visible furcation area. Hamp et al. In 1958 categorized furcation for the horizontal component into three degrees. In degree 1, horizontal loss of periodontal tissue support less than 3 mm is seen. In degree 2, horizontal loss of periodontal tissue support is 3 mm but not encompassing the total width of the furcation area. In degree 3, there is horizontal through and through destruction of the periodontal tissue in the furcation. Next we look for is the presence of pathological migration. The contributing factors for this are abnormal forces in the mouth and other deleterious habits such as tongue thrusting habits. Presence of pathologic migration of the anterior teeth in young persons may be a sign of localized aggressive periodontitis. Next is trauma from occlusion. Diagnosis of TFO, it is made from the condition of periodontal tissues. Periodontal findings which suggest presence of TFO include excessive tooth mobility, particularly in tooth that show radiographic evidence of a widened periodontal space, vertical or angular bone destruction, presence of intrabony pockets, and pathologic migration, especially in the anterior teeth. The tests to confirm presence of trauma from occlusion are Fremitus test and wax records. Next is tenderness on percussion. Percussion test, it is done to evaluate the status of periodontium surrounding a tooth. If there is a positive vertical percussion test, it indicates presence of periapical pathology. A positive horizontal percussion test indicates presence of periodontium associated problems. Coming to the gingival index by Lowe and Silnes in 1963, in this, mouth mirror and periodontal probe are used to record the gingival index on the distofacial papilla, facial margin, mesofacial papilla, and the entire lingual gingival margin of 16, 12, 24, 36, 32, and 44, after which the scoring is done. Score 0 means absence of inflammation or normal gingiva. Score 1 is mild inflammation, slight change in color, slight edema, no bleeding on probing. Score 2 is moderate inflammation, moderate glazing, redness, edema and hypertrophy, bleeding on probing. Score 3 is severe inflammation, marked redness and hypertrophy, ulceration, tenderness to spontaneous bleeding. Uses of this index is it is to determine the prevalence and severity of gingivitis in epidemiologic surveys and for assessment of severity of gingivitis in the individual dentition and in controlled clinical trials of preventive or therapeutic agents. Coming to the plaque index by Lowe and Silnes in 1964, this is similar to the gingival index in terms of the index teeth and the surfaces examined. But in this, we check for is the presence of dental plaque using an explorer. Score 0 means no plaque. Score 1 represents a film of plaque adhering to the free gingival margin and adjacent area of the tooth. Score 2 is moderate accumulation of soft deposits within the gingival pocket, on the gingival margin and or adjacent tooth surface, which can be seen by the naked eye. Score 3 is the presence of abundance of soft matter within the gingival pocket and or on the gingival margin and adjacent tooth surface. Uses of this plaque index is it is a reliable technique for evaluating both mechanical anti-plaque procedures and chemical agents, and it is also used in the epidemiologic studies. Coming to the oral hygiene index simplified by Green and Vermillion in 1964, In this, the index tooth are 1611, 263611 and 46, and the instruments used are mouth mirror and number 23 Explorer. Coming to the scoring of OHIS, 0 score means no debris or stain present. 1 is soft debris covering not more than one third of the tooth surface or presence of extrinsic stains without other debris regardless of surface area covered. Score 2 is soft debris covering more than one third but not more than two thirds of the exposed tooth surface. Score 3 is soft debris covering more than two thirds of the exposed tooth surface. The next component of OHIS index is the calculus index. In this, the index tooth are 1611, 26, 36, 31, and 46. Based on the scoring, score 0 represents no calculus present. Score 1 is supragingival calculus covering not more than one third of the exposed tooth surface. Score 2 is supragingival calculus covering more than one third but not more than two thirds of the exposed tooth surface or the presence of individual flecks of subgingival calculus around the cervical portion of the tooth or both. Score 3 is supragingival calculus covering more than two thirds of the exposed tooth surface or continuous heavy band of subgingival calculus around the cervical portion of the tooth or both. So use of OHIS index, it is in the studies of epidemiology of periodontal disease, evaluation of dental health education programs in public school systems, evaluating the cleansing efficiency of toothbrushes, and to evaluate an individual's level of oral cleanliness. Next comes the full mouth charting. It is done by using a mouth mirror and periodontal probe by exploring the buccal and lingual surfaces of all the teeth to obtain the clinical attachment loss. To obtain the clinical attachment loss, gingival marginal level is subtracted from the periodontal pocket depth. In cases of recession, periodontal pocket depth is added with the gingival marginal level to obtain the clinical attachment loss. Next is the provisional diagnosis. It is a tentative diagnosis or working diagnosis formed after evaluating the case history and after performing the physical examination of the patient. Now comes the records. In this, clinical photographs of the patients are taken. These photographs, they are useful for recording the appearance of the tissue before and after the treatment. They also depict the gingival morphological changes. Study casts are also obtained. They are useful adjuncts during the oral examination. They also indicate the position of the gingival margin, position, inclination of the teeth, proximal contact relationships, and foot impaction areas are also visible in the cast. They are important record of the dentition before it is altered by any treatment. They also provide a view of the lingual cuspal relationship and they serve as visual aid during discussion. They are also helpful to determine the position of implant placement if the case requires it. Coming to the investigations, firstly we take X-ray examination in which we have intraoral examination and extraoral examination. In the intraoral examination, we take periapical X-rays and bite wings. Bite wings are used to examine the proximal surfaces of teeth. To completely view the mouth, we require minimum 14 intraoral films plus 4 posterior bite wing films. In the extraoral X-ray examination, we have OPGs. Next is the hematological investigations, which include hemoglobin count, TLC, DLC, bleeding time, clotting time, ESR, blood sugar, fasting, and postprandial. So these tests they are required before any surgical procedures or in patients who are diabetic or they have any bleeding conditions. Then is the routine urine examination, exfoliative cytology, and biopsy. They are required in patients who have signs of any oral ulcers or white or red patches in the mucosa. Coming to the final diagnosis, it is reached after complete evaluation of the information obtained from the patient's history after physical examination, result of the radiological and the laboratory examination. So next is the prognosis. It is the prediction of the probable course, duration, and outcome of a disease based on a general knowledge of the pathogenesis of the disease and the presence of risk factors for the disease. So prognosis is made after the involvement of the risk factor but before the treatment begins. So it depends on the adequacy of the diagnosis and the quality of treatment, including the home care and the recall maintenance. Factors which are going to influence the prognosis are extent and the significance of the mucogingival problems, extent of furcation lesion, the combined periodontal and endodontic lesion, and the presence of hopeless teeth. So we have overall or individual prognosis, tooth associated prognosis, and site associated prognosis. So prognosis of a patient, it is dependent on various factors which include overall clinical factors, systemic environmental factors, local factors, and prosthetic restorative factors. So depending on individual factors, systemic conditions, local factors, and presence of any restorative or prosthetic factors, prognosis can be excellent, good, fair, poor, questionable, and hopeless. So coming to the last component of case history, that is the treatment plan. In this, emergency treatment is provided for dental or periapical abscess. Periodontal abscess is treated. Splinting of mobile teeth is performed and hopeless teeth they are extracted. Next is the etiotropic phase or the phase 1 therapy. In this, calculus is removed and root planing is done. Restorative and prosthetic factors they are corrected. Temporary and final restorations are done. Antimicrobial therapy is given to the patient where required. Occlusion therapy is performed. Minor orthodontic movement is done and provisional splinting and prosthesis is done, followed by maintenance of the patient. Next is the surgical phase or the phase 2 therapy. In this, endodontic therapy is performed. Periodontal therapy for pockets, gingival recession, furcation involvement is performed, and then the patient is kept for maintenance. Next is the restorative phase or the phase 3 therapy. In this, final restorations are done and fixed or removable prostheses they are given to the partially edentulous patients. After this, maintenance is done for the patients. So the last phase is the maintenance phase or the phase 4 therapy. In this, periodic checking is done for presence of calculus and plaque. Gingival conditions such as presence of pocket or inflammation is checked. We check for occlusion, presence of tooth mobility and other pathologic changes. And patient is recalled after 6 months. Please like and subscribe this channel.